Good afternoon and welcome everyone. I, Dr. 𝗖𝗏𝗧𝗧𝗦, on behalf of Voice of Healthcare, welcomes all the speakers and the viewers who have joined in for this discussion today on the topic of working together, uniting the voices for equitable cancer care, organized by Voice of Healthcare, powered by Zydus Life Sciences, and supported by the UN Global Compact Network India. This discussion brings together voices from various sectors to discuss the importance of collaboration and equitable access to cancer care for all. I would like to commence this session by introducing our eminent speaker. So, for this discussion, we have Dr. Ankur Bahl, Senior Director, Medical Oncology, Fortis Memorial Research Institute, Gurugram. Welcome, Dr. Bahl.
Good afternoon and
Doc-
welcome.
Dr. Nitesh 𝗀𝗏𝗏𝗧𝗏, Senior Director, Medical Oncology, Fortis Memorial Research Institute, Gurugram. Welcome, Dr. Rohatgi.
Namaskar, and thank you for having me on the show. Looking forward to a fruitful discussion.
Dr. K. Madan Gopal, Senior Consultant, Health, Niti Ayog. Welcome, Dr. Gopal. Dr. Somnath Singh, Lead Center of Excellence for Governance, Ethics and Transparency at UN Global Compact Network, India. Welcome,
Good
Dr. Singh.
afternoon. Good afternoon, everyone. Thank you very much, 𝗖𝗏𝗏𝗧𝗏, for having me here and provide me this platform to have a good discussion with the healthcare experts. Thank you very much, 𝗖𝗏𝗏𝗧𝗏.
Along with sharing his views, Dr. Somnath will moderate this session for us today. Over to you, Dr. Somnath.
Thank you. Thank you very much, 𝗖𝗏𝗏𝗧𝗏. Uh, and thank you very much, Voice of Healthcare, for having me here with the healthcare experts and the icons of cancer care. Thank you very much for all the eminent speaker for your concurrence and gracious presence at this panel discussion. Before we move formally to the panel discussion, I would like to give an overview of this special day, World Cancer Day. Cancer causes almost 4,59,000 deaths every year in the eastern region of the globe. Over the past 5 years, there were around 1.6 million cancer cases in the region, making it a continuous burden that expert tremendous physical, emotional, and financial strain on the individuals, families, and communities. Almost 7 lakhs individuals are diagnosed with cancer every year, and in 2040, it is predicted that the number of people being diagnosed will be about 50% higher. Cancer in India is on the increase with estimated 2 million new cases in 2022. 1 in 10 Indians will develop cancer during their lifetime, and 1 in 15 will die of the disease. Every year, February 4 is observed as World Cancer Day. It aims to promote awareness on cancer as a public health issue and to strengthen actions towards improving access to quality care, screening, early detection, treatment, and palliative care. This year's theme marks the second year of the campaign Close the Care Gap, which is about understanding the inequalities in cancer care and taking action to make the necessary progress to address them. Today, we gather here to discuss the significance of World Cancer Day and learn the strategy to close the care gap and recommendation to enhance knowledge on cancer treatment and policy and improve patient affordability and accessibility to cancer care services and facilities. And we have the healthcare expert with us to guide us on the theme for uniting the voice for equitable cancer care. So here, uh, Voice of Healthcare, in collaboration with JAT Healthcare and support from UN Global Compact Network India, is organizing this wonderful panel discussion. Uh, so I would like to just share the format of this panel discussion. So we will have our expert with us for 45 minutes, and at the end of the session, we will have question answer session from the participants. So thank you very much, the experts, once again. And uh, wasting not much time on this basic discussion, we just move to our eminent speakers to seek their insights and valuable thoughts on cancer care. So please put your hands together to welcome Dr. Nitesh. Uh, uh, Dr. Nitesh, uh, as to begin with, as you have long journey with cancer patients, and we understand you must have treated cancer patient at different stages, and you are well familiar with the ground realities of cancer care in India. So my first relevant question to you is, what are the key disparities in access to cancer care across different population in India?
Dr. Singh, needless to say, this is an extremely important question you ask. uh, and the disparity of care here, the difficulties in the cities versus the village, and even within the cities based on economic strata, whether you are being treated at a private hospital or a government hospital, and even within private hospitals, what economic reach you have has a impact on both your diagnosis, your treatment, and that is somewhat unfair. But if you look at the whole outcome, अगर हम ये देखें कि इफेक्ट क्या है कैंसर के डायग्नोसिस और ट्रीटमेंट का, so the biggest disparity is disparity of accessibility. People who can versus who can't reach a simple diagnostic test such as a blood test, a biopsy, and a CT scan. I'm not saying a PET scan, and I'm not talking about some few number of lakhs of rupees of testing. I'm saying a simple biopsy, FNAC, a PET scan, and a blood test. That accessibility is the biggest disparity, and in fact there is studies and data to show if we can meet that disparity with most likely a very disruptive module, we'll see a very big impact. Other than that, I do meet patients who can't afford the treatment, and we often say this: earlier you diagnose, the more the chance of curability, but also you will spend less money. So, especially people who think that time is money because they are on a daily wages, they must look after themselves. New lumps must be diagnosed, and they must do cancer screening because early diagnosis saves lives, but also saves money and, of course, side effects of treatment.
Thank you, Dr. Nitish, for your wonderful, suggestion and recommendation that the patient who is just suffering from cancer, definitely he should go for a best diagnosed, and they can just develop their strategy to get rid of cancer. Thank you very much, Dr. Nitish. Now, I would like to move to Dr. Ankur. Dr. Ankur, considering your great experience in treatment of the cancer patients and doing innovation to make the patient treatment easy and affordable, so therefore my questions to you: what are the latest innovation in cancer diagnosis, and how affordable are these emerging tools in India?
Yeah. Thank you, Dr. Singh. Sincerely appreciate your effort and sincere regards to Dr. Madan Gopal sir. So, your question is very straightforward. What is the latest innovation in cancer diagnosis? So, my first and foremost answer is that the eye, the brain to diagnose cancer has changed immensely in the country. Now, cancer is one of the differential diagnosis of every chronic symptoms or sign. So my physician sitting in different city or a different world or different state has cancer, one of the differential diagnosis that is most important. We are gone from an era. Our average life in India has increased immensely in last since independence. This is just because of diagnostic and technology. So most important latest innovation which you're talking about is diagnosis is beyond biopsy. We all know that cancer diagnosis is made by FNAC or biopsy, but in this era of 2023, when you talk about innovation, it is specific precision result of that biopsy. I do not talk about lung cancer these days. I talk about lung cancer adenocarcinoma mutation on exon 19 or exon 20 or exon 21 or ALK. I'm talking something different, and world knows it. A biopsy, there is more, this beyond biopsy which needs to be done for a precision and personalization. We'll talk about cost, but we are speaking absolutely beyond biopsy. We have to precisely know what is the reason behind this cancer and what is the remedy of this cancer, whether this remedy is a tablet, a chemotherapy, or immunotherapy, a targeted therapy, or a hormonal therapy, how best I can treat this, only when how best I can diagnose this kind of cancer and what is the specific type of cancer through which I have to target that cancer. So your next question is what all these tests. So now a new word is coming, and I will rather on this day of World Cancer Day, I'm giving you a new diagnostic tool which is called as liquid biopsy. We know that every time we used to biopsy a lymph node or an organ, we have to invasively go into the system and take out a tissue to diagnose it as a cancer, and then on further testing on these biopsy we know which kind of mutation or which kind of further test. Now the innovation is just take a sample from a vein as you do a CBC, KFT, LFT, and that liquid biopsy detects those tumor DNA, and we can do further analysis. This is not for every cancer at diagnosis, but repeat cancers, relapsers. So liquid biopsy, and we should be proud that I will not name it, but that the country has Make in India liquid biopsy, which is well known in world, and they have set their standards so well that a sample from a vein on an arm can further test me which kind and what is the further remedy. The other question is the cost of these diagnostic. So we know in health or similar to any industry, with time the cost comes down. So when we dreamt about these tests in our textbook, it was just a dream. Then we started knowing where these tests can be done. So the sample decade back or 5 years back used to go to America, Singapore through various channels. Now these channels are available. Indian market, Indian industry is doing all these tests at a cost which is one fourth or probably one eighth of the standard, and it is standardized. The specificity and sensitivity of these tests are standardized. But yes, when the numbers will grow up, when these companies, the generic companies, will be doing more and more tests, I'm very sure the cost will come down to as low as 150 or $200 per test, which the data which India has is so immense that this cost will come down drastically, and will be, and more tests are done, more research will be done, and oncologists will be knowing about these tests more often. So ultimately patient and science will be benefited by this test. So all the innovations are happening, and India is not lacking any standards when it comes to cancer diagnostics in India.
Can
So
I
thank
add
you.
something to that, Dr. Singh? I think Dr.
Please.
Bahl made some really wonderful points, and we must keep them secure. And if you add a little bit of a futuristic view to technology, I am certain that the additional layer of digital pathology and artificial intelligence, when it gets added to what Dr. Bahl was saying about precision oncology, when it will add to what Dr. Bahl was saying about liquid biopsy, trying to diagnose a brain tumor by a blood sample, then the digital pathology, which will decentralize. Your skill is poor, but the digital microscope can go anywhere in the world. So when digital pathology and artificial intelligence adds a layer, we will see a very different world. And I will add to that also, India will lead in this, not the world, because accessibility is an Indian problem and innovation is an Indian dogma. And I think we are better innovators than anywhere else in the world.
Thank
So
you.
Singh,
Thank you, Dr. Nitesh. Yeah.
I want to
Yeah.
make one short comment to this innovation. So pre-COVID, just take yourself pre-COVID era and the post-COVID era. Today morning, 8:30, a patient from Madhubani, Bihar, contacted me on this portal, on a video portal, and I gave him the diagnosis and my expertise on a video. And the patient was sitting 2,500 kilometers away from me. He approached a cancer doctor on World Cancer Day through his mobile. This is a huge innovation. Patient had to travel so long. They could not meet a doctor because of many reasons. And now the Madhubani patient or a Muzaffarpur patient or a Patna patient or a Guwahati patient can contact a Gurgaon doctor by taking a proper right appointment within minutes. And it seemed that I am just a few meters away from Mr. Dr. Somnath Singh and Dr. Madan Gopal and Dr. Nitesh Rohatgi through this media. So this social media, these channels, this technology is the best innovation which science has given to our patients.
True, Dr. Bahl. And the point you just mentioned here, definitely, because the mind of the people are changing about the diagnosis of cancer, and also lots of innovation are being done in India. My next question is very relevant, very related to you, Dr. Bahl, because as you were talking about innovations, uh, 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 just few days back I had a discussion with some oncologists, and they were just talking about the cancer detection now has changed to the cancer connect. So what is this terminology, why the oncologists are using this term cancer connect, which is not only just providing lots of guidance to the patient, but also it is just bringing different stakeholders at one place to work together to combat cancer. So can you just elaborate your thoughts on it?
So Cancer Connect means first of all accepting the word cancer,
Okay.
accepting treatment of cancer, which is surgery, radiotherapy, chemotherapy, immunotherapy. So the country has to move forward when it is the second most common cause of death among the non-communicable diseases. The amount of financial burden, the amount of uh, economy, what I call is oncology economics, oncoeconomics. So we are talking about treatment, immunotherapy, chemotherapy, targeted therapy, next generation sequencing, the cost of NGS and the cost of liquid biopsy. But we are not talking at ground level about the screening program.
Yeah.
So this is Cancer Connect. A patient has to know that before detection of stage 1, stage 2, stage 3 or stage 4, before, so 75 to 80% of my OPD load is still stage 3, stage 4. Why it is not stage 1, why it is not stage 2? Because the country, the population is not, still haven't accepted the screening mammography or a pap smear. It is उल्टा हो रहा है कि डॉक्टर बता रहा है कि स्क्रीनिंग करो पेशेंट के दिमाग में, कम्युनिटी के दिमाग में, कॉमन मैन के दिमाग में जब ये आ जाएगा दैट स्क्रीनिंग इज मोस्ट इंपॉर्टेंट टू डिटेक्ट अर्ली, then we will. So this is just a way. Cancer Connect or Onco Connect or Surgery Connect or a breast cancer, we are celebrating every month a organ specific month. It is just to connect with people and give this spark in their mind that please screen. We will get many stage 1, we get many stage 1, we will cure many, and then only we can win this disease. We have to connect. Until unless we connect, and connection is a continuous process, it will, this connect will go on for next millions and trillions of years. Innovations will be connected, biopsies will be connected, and education will be so connect is education. Education never has boundaries, it is a continuous process.
Oh,
Yeah, and
thank you very much.
again, if
Yeah.
I may add, I think we speak too much, so I'll keep quiet after this. But the whole idea of Connect is not new. We've had tumor boards discussion in cancer for decades together. But post COVID, as Ankur said, our connect has become easier. We are now discussing a patient, which as oncologists, in fact, we were trained to. We were trained to not treat by ourselves. We were trained to discuss with peers. But with new technology, with Cancer Connect, we are connecting to peers all over the world, in fact, and seeing what is the best path for the patient forward.
Oh, thank you, Dr. Nitesh, and thank you, Dr. Bahl, for your wonderful insights. Now, this is the time to move to the Gorvin side. So, I would like to request Dr. K. Madan Gopal. Dr. Madan Gopal, with regard to health, Niti Ayog has been mandated to develop model concession agreement for the provision of prevention and treatment services for non-communicable disease. namely cardiac sciences, oncology, and pulmonary science at the state and district level. So, based on your experience and policy making body of Government of India, would you please share your thoughts on what steps the healthcare providers and policymakers should take to improve access to cancer care for all individuals?
Thank you, Dr. Singh. I will share what the government is doing. I can't be
Yeah.
prescribing things to the government as the question has been framed. What government needs to do. That's your domain, and you should always be talking, saying that the government should be doing this and that. Because working with the government, I can only share what is happening in the government level and what the government is doing for taking care of the cancer and the cancer things. Having said this, I will just share that how the policy shapes the innovations and other things, taking clue from what Dr. Bahl was saying. Before the COVID, telemedicine, teleconsultation, video consultations have all been taken seriously by the honorable courts, and lot of strictures have been passed against the doctors. And you see how the opportunities are being used for creating policies and enabling environment. During the COVID times, it was an opportunity, and our honorable member was at that time the chairman of board of governors, and we have facilitated that telemedicine guidelines, and which have enabled and created a ecosystem. Now you have seen how the telemedicine is growing. At that time, it was a requirement, and we started it not for treating of the COVID patient, but for continuum of the care for the morbid patients, because that was only meant for to see that the continuum of care is there. This was one aspect. See how the technology changes. I will add to the other aspect. We have to move from the surgery, chemotherapy, and the radiation to some more advanced techniques, because uh, there is a perception among the people, that means slash burn and slash poison and burn, that kind of things. They are afraid about that. We have to understand why screening is not happening in the country, despite having a non-communicable disease program. The previously bigger name has now been shortened to non-communicable disease program, which has cancer screening. If you look at the structure in the National Health Policy 2017, we have a policy enabling environment which talks about how to create an enabling environment as well as support innovations, the digitalization, everything is there. Then you see how the policy have moved from a primary care approach to a comprehensive primary care approach. We were signatory to Alma-Ata Declaration. We have agreed for health for all. We have agreed for Millennium Development Goals. We have agreed for Sustainable Development Goals, and we have agreed for universal healthcare. These are the policy enabling things are there to aid that. The vehicles are the four core programs, that is Ayushman Bharat Health and Wellness Center, the Ayushman Bharat PMJ program, the infrastructure development program, as well as the digital mission. We are having four enabling programs. You see, the Ayushman Bharat Health and Wellness Center, because our policy says that we have to infuse more money in the preventive care, the primary health care. Because if you look at the number of cancer beds, the total number of beds which are providing cancer treatment, are they adequate? They are grossly inadequate. Even if I am able to create 5 lakh more cancer beds, will that suffice? No. The way things are evolving, the social determinants and the other factors which are coming in, which are causing cancer, unless you just make investment into that area, that is prevention of cancer, you will be just struggling and saying that that's the other end of the spectrum. That means providing treatment. Already we are having a network of institutions, though they would be inadequate, but we are able to provide services to that. As the topic is the inequities, you see, if you look at the out-of-pocket expenses, the standing committee report of the Parliament Standing Committee report also say that 40% of the cancer care is being funded through mortgage, through selling of distress selling of their assets, as well as borrowing. How to address this thing? And look at the out-of-pocket expenses. We are having, if you look at the genesis of this, you will understand the policy perspective, how these policies are designed to aid the common persons and come to their help. As per the latest figure, the NHA data, the National Health Accounts data, the household is spending 48% of their medical expenses through their pocket. That means 50% of the healthcare is being purchased by the people themselves, and mostly for the drug diagnostics and your imaging and other services, mostly, and the OPD care. And we are having program. PMJ is one of the program which is addressing that thing, wherein it's a kind of public-private partnership. Private hospitals are also a part of that. In PMJ, we are having around more than 1,500 packages and around more than 130 oncology packages, including surgery, radiation, and chemotherapy. This is an enabling thing which has been
And
created in PMJ program. But this is not restricting. In PMJ, we have talked about the having a cancer board, and the cancer board would be deciding on the therapy. And even if the package is not listed in the PMJ, you can always take a pre-authorization, and if the number of packages in that pre-authorized thing happens on a more frequent basis, that can be considered for inclusion as a package. Packages are for just administration purpose. Apart from that, to aid and to reduce the inequalities, because if you look at the suffering of the people, the suffering of the family, if a family is detected as any person in the family is detected having cancer, as they are coming in stage 3 and stage 4, they know that it is not curable, and they don't want to disclose it also. The earning member usually try to hide it, because the moment he knows that the cancer is there, then he's nowhere. His earning capacity, everything goes down. If a person is diagnosed, if a person is having a cancer in the company, and that family goes by 10 years,
yeah,
and every year 4 crore population is getting into the impoverishment due to this kind of elements, these NCDs. We are factoring in that, and we now see that how, because giving a treatment support and other thing, that's one thing. We can't be treating all the patients. That kind of support can't be given. PMJ programs are there, health insurance, that kind of uptake is not there. Then if you talk about if you look at the structure, the consumption pattern based on it, the upper quintile will always take care of themselves through some program or for insurance. Lower quintile, government is taking care. But what about the middle one? Of this middle one, the bottom of the middle one, they are the they are the targets. They can go either that way or this way, and usually fall into the bracket of the poverty. And all of the policies which we are making, we are trying to address these issues and discrepancies, and reducing the inequalities. I will stop here and
thank you,
we'll take other questions.
Dr.
thank you very much.
Can I
Thank you
make a
very much.
comment to Dr. Gopal, Mr. Singh? I
Please,
think,
please,
Dr. Gopal,
please.
first of all, absolute kudos to you and the team. And I think what Niti Ayog and Ayushman Bharat have done is unique in the world. It's not unique in India, it's unique in the world. I think it's actually a pat on the back on the government and everybody involved. Need of the hour and done very well. But I have only, and I heard you very carefully, and I have only one question or two questions there. We know that if a fixed amount of money has to be spent, it should be spent A, in prevention, and B, in early detection. And we know the cost of treatment will come down drastically if we take away tobacco to whatever level we can, if we vaccinate people for cervical cancer at HPV level, and absolutely make screening essential. If we start saving people's taxes, maybe. Now, my point is that the amount of money spent in cancer treatment is always going to be fixed. I would rather spend that money at 1/10 the cost of surgery alone than actually be giving immunotherapies to that patient, which will break the back of the entire government and the patient's assistance. So just my point or a response from you would be very nice. Thank you.
Thank you very much, Dr. Nitesh, and thank you very much, Dr. Madan Gopal. But the valid point you can mention here that the government has the framework for enabling environment, and the healthcare units are just implementing those framework. As you rightly mentioned that insurance. But still, I'm just seeing the insurance policy. They have not made any provision for cancer patients, whether with regard to the diagnosis, with regard to the testing, with regard to the treatment. So the government is having some, the plan in this regard to just, ask the insurance company to include cancer diagnosis or treatment in their policy.
Dr. Singh, if you look at the PMJ program, nothing is restrictive there. If I have mentioned that there are 130 plus oncology packages, including radiation, chemotherapy, where the cost of diagnosis as well as the scanning and other things, biopsy and other things are included. But if you look at the way the preferential provider network of the insurance companies have evolved, that has evolved when the RSVY was started by government of India way back in 2007-8. That has created confidence among the insurance companies that yes, we can have package rates for this, and they negotiate that package with the hospitals.
No.
So they are working.
But
I can't say what they are doing,
Dr.
but the
Gopal,
insurance companies they
but
usually
Dr.
take
Gopal,
from.
unfortunately, the insurance companies still don't cover diagnosis of cancer, and they don't cover oral therapies, which is now 50% at least cancer treatments. And to my mind, they will not cover till actually we as advocates and the government together force them to do that.
Yeah, okay, got it. As I mentioned, if you look at the insurance sector, if you look at the way the population is assured, 50 crore population are covered by PMJ.
Yeah.
Another 14 crores are covered by ASIS scheme. 3-4 crores they are covered by CGHS and others. That means around 70 crore population is there, of which only 4-5% they take insurance. For
Okay, good point.
you
True,
got
true.
my point now. Unless
Yes.
because they usually look at
Yeah,
what
yeah.
the government is doing. We are having that kind of package. Usually they make their package great based on the experience which the government schemes are having. The preferential provider network which the insurance companies they have created, which they negotiate with the hospital now, that wasn't that that confidence they got it after the RSPY rates package, though it was very less, but it has given an idea that they can move in that direction. With the
Thank
experience coming from PMJ program, I think they would be working in that direction. I can't be commenting what they are doing, what they are not doing, but I learned that some of the groups they are working in this direction, and they shortly would be including these packages into this.
thank
Previously,
you.
mental was not there, but with lot of efforts and other things, mental packages are now also built in. So
Thank you, Dr. Madan Gopal.
they are
Thank, thank,
innovative usually. Yes.
thank you very much for the wonderful clarity and the insights from your side. Now, I would like to move again to Dr. Nitesh. Dr. Nitesh, we have an excellent infrastructure and services to support cancer patients in the metro cities. However, the penetration or accessibility is lacking in the rural areas. So, how do you think we can overcome this inequality problem in India?
Well, Somnath ji, I think very well pointed out. We are aware that the bigger society of India lives outside the six big cities, and we are also cognizant of the fact that the care in the cities, the diagnosis and treatment of cancer is either and mostly not existent, and when existent is fragmented, and at times, and I'm very sorry to acknowledge, corrupt. And these are very key issues that cannot be addressed by us alone. We again I say this, and I think that's what I was saying when Dr. Gopal was speaking. It requires advocacy, the private health sector, and the government to really tie hands together to make some kind of a policing and some kind of deep dive into what can be accessed there. But in addition to that, I very strongly believe innovation will show us the way. I strongly believe that the skill is limited. So if we start making at least the already skilled, let's say, 1,000 oncologists give 5 hours of their time in a week and create command centers where they can achieve accessibility to the villages and to the remote corners. If you put a digital pathology where you need a technician to be trained up to just put the slides up and the main pathologist can read, and if we then put artificial intelligence, I think we'll go a very long way. Now I'm going to add another layer to that, and this is one of the lectures I gave for King's College Policy Institute UK, that if West, which is the entire US and Europe, if they really want to solve their oncology problem, they will have to invest in the East to get data points, analyze that, to really understand what cancer is all about. Because cancer cannot be about giving 4 lakh rupees therapy to people every week. It has to be about early detection, early treatment, timely test, and the bulk of treatment. So I think, to summarize, going out requires innovation, command centers, decentralization of care with a centralization of skill, and certainly using as much innovation as we can from West and giving them the data back to understand cancer better.
Oh, thank you, Dr. Nitesh, because my next question is very relevant to you. Dr. Nitesh, I was just going through some reports and I have interaction with the experts there that I found that the services related to cancer care is very much high, very much good in the southern region of India. But when we comes to the northern side, we find the services and the facilities are very less in number. So what do you think? What are the factors why the people in northern India are not very much serious for this cancer care? Rather than we have good facilities, good services in southern side. So can you just elaborate your thoughts on?
Dr. Somnath Singh, you picked it up so well, and this is one topic which is very close to my heart. The biggest problem is psychological. The bigger problem is the doctors and the community in the north, in my mind, is hyper competitive. We are taught from class 1 that if you're not first, you fail. So when we become this superlative doctors, we don't want to collaborate. We want to compete. And I see opposite in South. I see they are realizing, they already know this from now second generation, whether it's business or healthcare, that the real growth, even of the individual, happens with collaboration. So the structure that the South has created, which is a collaborative, informative, and therefore follows a pattern, a conveyor belt approach. You don't miss anything. Is opposite of North, wherever the patient lands up with, and I'm not talking about private healthcare alone here, surprisingly, even the government healthcare. In fact, you'll see that in the USA as well. USA is the pinnacle of hyper competitiveness. And there are papers in USA as compared to Europe, where when the patient lands up in the hand of a doctor, the bias screams in, the structure goes away. So I think, again, it is about creating a structure by government, by combined institutions, where people start seeing their own benefit in collaborations and creating structures around that. That's the only solution to this. I think Ankur wants to make a point.
I want to make a comment to the why North India and why South India. If you go to the history of oncology, as a student, we were being taught this also. So Adyar Cancer Institute, the first cancer institute of the country, was in 1952 when it was Adyar Cancer Institute, and then it was made as a regional cancer institute. And I'm not an alumni of Adyar, but we have been in our training program and in our oncology thing,
Very
we used to
proud.
always feel like what Dr. Muthu Lakshmi has done in 1952, and then how it went along. And Adyar, if you still go to Adyar, you take a round of Adyar Cancer Institute, it gives you a feeling how it would have started in 1952. So the birth of oncology, the concept of oncology, the cancer, surgery, treatment, radiation, chemotherapy, the seeds were sown in South India, and the system around that was oncology in Adyar, then Tata Memorial, Kidwai, AIMS, then North India AIMS, and certainly the history of regional cancer institute. If we used to talk about few regional cancer institute, now there's a huge list of RCC, regional cancer, the National Cancer Registry Program, which was in 84, and National Cancer Control Program, which was in early 70s. The whole emphasis was given to the registry program, that to know your patients, know your data, know your epidemiology. So until and unless we know our epidemiology and the problem very well, the solutions are far behind. We need to know the problem, and Adyar and Southern India was first institutes of the country where they started the concept of cancer, what is cancer, and can it be attempted to treat. So I think the history of oncology program in India answer this question rather than the uh, concept,
Yeah,
understand literacy, and all. There are various factors, but I think this is most important factor.
yeah. Thank you very much, Dr. Bahl, for your wonderful detailed information. Why the services related to healthcare is very much high in
Cancer
southern Asia.
related. Cancer related.
Cancer related, and definitely the people should change their mindset in northern side so that we can strengthen the health seeking behavior among them. So my relevant question to you, Dr. Bahl, once again, because now we are talking about a lot of things on innovations, and people needs to do innovations to strengthen cancer care. So my next question to you, that what recommendation do you have for future initiatives and policies to support equitable cancer care in India?
Dr. Madan Gopal sir is there. I will not give any recommendation. I will give some suggestion which my brain and my soul thinks for these cancer patients. I will just quote few examples, sir. My age is, suppose I'm a female, my age is 39, and I have a insurance, either a private insurance or a government policy, CGHS, ECHS, whatever. I should not be given insurance next year if I don't have a pap smear. The country actually runs through this Danda effect. So if I don't have a, if I, my driving license expire, I will run to the authority to get a driving license. If my passport expires, I will run through the passport MEA office to get my passport because I have to go to Dubai. But why my insurance is getting renewed? Why government, by just a tick mark method, that pap smear has not been done in a female at the age of 39, and if it applies and a mammography is not done by a female at the age of 49, forget about 40, 52. So why insurance should be renewed? There should be, people should run for the screening program rather than a doctor or an institution or a government run for a screening program. My emphasis is on screening. My second suggestion, or my mind thinks, is National Cancer Control Program was built in 70s, early 70s. National Cancer Registration Program was 84. Somehow, if I see National Cancer Control Program or National Cancer Registry Program, we are sitting in 2023, and I might be lacking some knowledge or I'm not updated. Somehow, after 2005, the innovations have stopped in National Cancer Control Program. It's a matter of state, it's a matter of health ministry. Why National Cancer Control Program emphasis is lagging, why we are talking about liquid biopsy innovation, we have to go back our program again. There's mention of cobalt machine, IGRT, IGMRT, palliative, they all have been mentioned. How much it has been achieved, what is the delta is huge or something has been achieved. This has to be come down into National Cancer Control Program, registry program. Registries have to increase. The disease of gastric cancer is mainly of Kashmir and Kerala. Karnataka is something different from the gastric cancer which is found in Guwahati. So we need to know our trends better. The third thing which my mind think about cancer, and what suggestion or recommendation is a strong word, that somehow in my basic MBBS program, cancer is being taught in anatomy, physiology, pathology, medicine, surgery, a bit of cancer, since cancer is a such a leading cause of morbidity and mortality in my country, and it will grow on further and further. I think that somebody should, there are 19 subject in MBBS, why can't it can be 20th subject in MBBS? When I ophthalmology is being taught in anatomy, pathology, physiology, and biochemistry, then again we read ophthalmology in my final year. I read ENT in my first year with anatomy, and ENT in my final year. Why can't we have a cancer as a 20th subject in my MBBS course, so that a ground level doctor or a worker or a nurse should know this disease, and when these disease, it will be in my DNA of a doctor in understanding one of the differential diagnosis. He will take it forward to his MD program, DM program, or even in an MBBS program. Cancer should be a big subject rather than just a chapter in every organ.
Oh,
Uh,
thank you, Doctor.
can I add? I think
Please.
Dr. Bahl already made great points, but I will make a suggestion which Dr. Bahl was refraining from making. I think people who are screening should get tax deduction by the government. And I think that will not only give them incentive, but it's a continuous noise. It's a way of giving awareness, because when you're putting up in front, have you had screening, you can get that deduction. they will think about it on a yearly basis. So that's just a suggestion, and I wonder if it can be taken forward.
Thank you very much, Dr. Nitesh, Dr. Bahl. Wonderful suggestion you have given how we can just innovate in India to improve, cancer care. Sir, Dr. Madan Gopal, because I know about you, you have, very good experience of improving public-private partnership to strengthen healthcare sectors. Because, so sir, what do you think? How we can just, strengthen public-private partnership and community ownership to make this cancer care project a successful initiative in India, sir?
We are already doing things, as you have mentioned in your opening remarks when you were introducing me. We are having a concession agreement where we are seeing that how the existing institution, public institution, can be used for this cardiovascular cancer and other treatment. So that kind of concession agreement is there because that was one of the hindrance factors. Without, in absence of concession agreement, people were not coming forward. But that concession enabling thing is there. Apart from that, the Department of Expenditure usually have a scheme. This is viability grant funding scheme is there. They usually fund that, fund any of the institutions which are coming in a PPP mode to encourage a public-private partnership in the country. And the third example which we are seeing is participation of the private sector in the CGHS. Even the ESIS also is coming with private sector. And the Ayushman Bharat PMJ program, they do have good participation, around 6,000, 7,000 hospitals from the private. It's a kind of private because they sign an MOU, and based on the MOU, they are empaneled, and based on the agreement, they usually treat the patient and give services. Another important aspect which is happening is the National Cancer Grid, which talks about creating a uniform cancer treatment, screening, as well as research on the cancer across the country. This has been done by Department of Department of Atomic Energy, and the Tata Memorial Hospital is spearheading this. And so far, they have created around 300 centers, which would be undertaking the research and seeing that how a uniform cancer treatment can be made available across the country. One of the important things which we are doing, if you understand the health structure, the public health structure, we have a beautiful structure which has evolved over the years as the strategy was there. At the village level, we are having a worker which caters to around 1,000 population. He's a community health volunteer. We call them as ASHAs. For every 3,000 to 5,000 population, depending on the terrain, we have an institution, which now we call it as health and wellness centers, which is having a BSc nursing person as a community health officer, assisted by 2 auxiliary nurse midwives or female workers. And that means one institution is catering to around 5-6 villages. So with the help of this network, this setup, one of the mandate previously, this was providing 6 services, which was mostly focused on RCH and your communicable, few of the communicable disease. Now the population-based cancer screening has been added to the mandate, and it is evolving. It started in 2017-18. Now, in the coming days, you will be seeing a lot of screening happens. Screening undoubtedly has been very low in the country. US, they are screening more than 95%. We are screening only 1 to 5% of the population. The women, as he has mentioned, that how many, if you talk about the cervical cancer screening, it's hardly less than 5%. Whereas in US, it is more than 95%. With 95%, they are detecting a volume of cancer patient, and with less than 5%, we are detecting a similar number of numbers, with the same numbers if you talk about the numbers. This program is going on, it is going to pick up. Currently, the focus is on oral cancer, lung cancer, and the cervical cancers. Breast cancer and the cervical cancer. This is at the community level which is happening. And from 2005, a lot of community participation has happened into the health system, public health system. The private sector usually grew up during the mid-90s. Before that, it was the only public sector institution with scarce presence of private sector in this. With the liberalization, they have evolved, and the footfalls in the private and the government are same. More 50, but the expenditure happens more in the private sector side, around 70-75% expenditure, healthcare expenditure. That to 50% of it is coming from the patient pockets, not from the insurance and other things. We have to see that how to reduce that thing.
Yes, yes, true,
As we are
true.
talking about cancer, we see that this mechanism is there. The cancer control program, which was imbibed at the district level hospitals, at the community health centers, we are having cancer treatment facilities. We are trying to see that how we network with the bigger institutions so that after the diagnosis, the treatment can be provided near to that person. At the health and wellness center, we are trying to see that how the palliative thing is also added into the extension services which is there. This network has evolved. The first contact of the with the medical personnel is at 20,000 to 30,000 population through primary health center, where you can find a MBBS doctor. That means with
Yes,
this network, there are a lot of pilots which are going on with the help of a few cancer
yes.
institutions. They are training the doctors after the initial screening, as Dr. Bahl was pointing out during that with the help of technology, they are having the groups. Even for confirmation, they usually seek the help and the treatment is instituted then and there only. That kind of network is also evolving. But you
Thank you.
see, as the things are evolving, we are focusing on screening because even if we create a huge infrastructure, that would be
Yeah.
inadequate unless you have some preventive measures in place. Because the social determinants really becomes very important in the coming days.
Thank you, Dr.
And
Madan Gopal.
Dr.
Thank you
Madan
very much.
Gopal, sorry, sir,
Uh,
Dr. Madan Gopal, just a quick question. Are we capturing data on all these interactions that is happening between people?
Yes, because if you talk about the other mission, which is the National Digital Health Mission, apart from that, in the public health system, you are having two big programs. One is the IDSP program, which talks about which captures each and every data right from the village level, each and every individual, if they are reporting any symptoms, other thing that comes to the system, integrated disease surveillance program. The other is the HMIS system. Whatever actions, activities is done by the health worker at the village level or at any place that is captured by the system, it comes to this. But from the private sector, except the TB and a few of the communicable disease which are to be notified, we are not getting much information. But COVID has shown us way that how the private sector can also feed in information if it is required. The COVID information which is coming through the S3 portal, that kind of mechanism there. We do have a digital infrastructure which will aid in getting information from that. Apart from
thank
that, this cancer, at the cancer also, we are having cancer registries as you have mentioned. But important thing is how to make people aware that they require to be screened and they could come forward and so that we can see that how the cancer registry can this. But the National Cancer Grid, which has been spearheaded by Tata Memorial, I think with the spread of around more than 300 centers, I think we will be getting more data, and in the coming days, you will be seeing more about how the things are evolving in the cancer space.
thank you, Dr. Madan Gopal, because I have lots of questions to learn from you experts. But this is the time to move to the participants to just share their questions so that we can respond to them. So, Ritika, can you help me to just have questions from the participants? uh, Dr. Nitesh or Dr. Bahl, can you just respond this question?
So, how can I see a question? Is it
think
The
how do
question
you?
is
the
the
question
question.
is
After
the
cancer
question is
diagnosis.
main challenge after cancer diagnosis is fear in person's mind, and how do you think of a common man can access right doctor after diagnosis? So first of all, I think a very important point, and Ankur tried to make this, is the fear should be before a diagnosis, and you should use the fear. Fear को हम हमेशा बुरा मानते हैं. Fear is a good thing. It's an evolutionary trait. You should use that fear to detect in time, screen and detect in time. But once you're detected, unfortunately, you must, and today's world is much easier. I insist you must take a couple of opinions. And the doctor who is talking logically, and now there's information on the net, is kind of meeting the guidelines, is the right doctor. Thankfully, we have a lot of Indian guidelines. We have ICMR guidelines, we have Tata Memorial guidelines, and we have our own institution guidelines. Fortis Cancer Institute has its own guidelines, which we are using. And so you should ask, is this what you usually do? And every cancer is structured. Diagnosis by radiology, diagnosis by biopsy or FNAC, and then treatment, which involves surgery, chemotherapy, radiation, some of these, all of these, none of these, and sometimes just tablets or immunotherapy. So think on these lines, and I think you'll get it right.
Thank you.
मैं
Thank
इस
you.
I
Yeah,
will take
please.
this question in a very easy manner और in English कि अब जब एक कॉमन आदमी को कैंसर डायग्नोस हो जाता है, उसकी रिपोर्ट 6:30-7 बजे आती है, तो वो किससे पूछेगा और क्या पूछेगा कि क्या आगे करना है. So he will have three options. He will either call a senior person in a family, or he will call a local doctor which is accessible to him, or there is an education which has inbuilt into the system. So we should work at all the level. वो जो सीनियर बंदे से पूछेगा, अपने चाचा मामा या किसी बड़े बुजुर्ग से पूछेगा, उस बड़े बुजुर्ग को नॉलेज होनी चाहिए. सो दिस नॉलेज अबाउट कैंसर शुड बी डिसेमिनेटेड लाइक व्हाट वी इरेडिकेटेड पोलियो आल्सो. पोलियो की खुराक के लिए, दवाई के लिए हमने क्या क्या नहीं किया था जब हम छोटे बच्चे थे, जब हम
जी,
इंटर्न थे, हमने कहाँ कहाँ जाके बूंदे पिलाई हैं. तो सिमिलरली उसी लेवल पे हमें एजुकेट करना पड़ेगा कि कैंसर का डायग्नोसिस अगला स्टेप क्या है. वो डॉक्टर जो कम्युनिटी में बैठा है, चाहे वो डीएम हो, चाहे एमएस हो, चाहे एमबीबीएस हो, वो एक आंगनवाड़ी वर्कर, वो एक आशा वर्कर, उन सबको थोड़ी थोड़ी नॉलेज होनी चाहिए और फिर वो उस डॉक्टर तक पहुंच पाएंगे जो इसका मेन, या संस्थान तक पहुंच पाएंगे जो मेन इलाज है. सो आई थिंक एजुकेशन इज द की टू अ कॉमन मैन, चाहे वो नक्सल इलाका हो, चाहे गुड़गांव का मेट्रो हो, चाहे न्यू दिल्ली का ल्यूटेंस हो, या केरला का एक गांव हो. हर जगह ये यूनिफॉर्म एटलीस्ट कॉमन मिनिमम एजुकेशन मिलनी चाहिए कम्युनिटी को, जहां के उनको पता हो कि नेक्स्ट स्टेप क्या करना है.
thank you. Thank you
Yeah,
very much, Doctor.
Dr. Santosh, I just want to add one thing is when the having associated with the HIV program, जब start किया था, जब testing करते थे, तो why the counseling is very important before testing. We can have a similar approach because if we are submitting somebody for diagnosis of a cancer, the patient should be aware that why that screening is happening, what could be the result. If it is discussed upfront, कि पहले ही बात कर ले उससे कि आपकी स्क्रीनिंग हो रही है, डायग्नोसिस हुआ, this could be the results. And if the patient is ready, that fear and other things can be reduced to a large extent. And many of the hospitals, they have started this counseling before the diagnosis and the other procedures are being carried on that patient. That's a key for this.
Yes, yes, you rightly said, because informed choice should be there for the patients. Thank you very much, Dr. Gopal. Ritika, do we have another questions from the participants? This is, are there any insurance which cover cancer care? No, doctor has already, mentioned about it, and lots of discussion we held. The next question in, can we in India enroll in the clinical trial for cancer treatment as they do in Western countries? What is
So
the
the answer
protocol?
is India is involved with lots of clinical trials. Actually, it's a bit of a myth कि India में clinical trials नहीं होते. India is involved with lots of clinical trials, private institutions, All India Institute, Tata, Adyar, and many of these drugs are very expensive, new technology drugs. And there is a group of oncologists which is on WhatsApp, and we talk to each other and see what's available across India. But if you even Google, and many of these even cancer NCI, you will see Indian websites, and so it can be searched, and you should do that when you are planning a treatment for that.
और कई बार ये होता है कि जब हम एक टेस्ट कराते हैं, वो टेस्ट की रिपोर्ट किसी और कंट्री में जाती है, वो टेस्ट की जब रिपोर्ट आती है तो वो बताता है कि इंडिया में भी एक सेंटर है क्लिनिकल ट्रायल्स का जो इस दवाई में, विशाखापट्टनम में एक्स डॉक्टर वाई डॉक्टर इस दवाई पे कर रहे हैं. तो कई बार हमें भी पता लगता है कि अपने ही देश में एक डॉक्टर इस बीमारी के ऊपर ट्रायल कर रहा है. सो इट हैज टू बी, वी आल्सो नीड्स टू बी एजुकेटेड अमंग आवरसेल्फ. हमारे ऑन्कोलॉजिस्ट 250 ऑन्कोलॉजिस्ट का एक व्हाट्सएप ग्रुप है जो सिर्फ ट्रायल ग्रुप है. किसी को कोई मदद चाहिए, हम लिख देते हैं कि ब्रेस्ट कैंसर का, इस सबसेट ऑफ ब्रेस्ट कैंसर का कोई ट्रायल चल जाता है, तो कोई बताता है कि हाँ मेरे पास है, तो हम डायरेक्ट करते हैं. So this is very common in India, and we are evolving with this. Yes.
Yeah.
Thank you. Thank you very much, because Ritika, I think there is no question because we are running short of time. So this is the time to conclude the session. So before I conclude our wonderful discussion, I would like to request each speaker to share at least one way forward and suggestion or take-home message that can help strengthen healthcare sector in India, especially to increase cancer care of the patient.
If I will start, thank you for this opportunity. please, one thing, and I'll say it again: stop smoking, no tobacco. Stop smoking, no tobacco. Stop smoking, no tobacco. Next year, I'll say the same thing. The year after that, I'll say the same thing. Till tobacco goes away from our country, I'll keep saying, stop smoking, no tobacco.
Thank you, Dr. Nitesh.
So I will use next 25-30 seconds to emphasize that tobacco causes cancer and I say cancer cures tobacco. जब कैंसर हो जाता है तब हम टोबैको छोड़ते हैं. My next punchline for today is detect to protect.
Oh,
पहले पहचानो फिर बचोगे तभी जब स्टेज 1 में डिटेक्ट कर पाएंगे. और मेरा तीसरा पंचलाइन होगा जो पैलिएटिव और पेन फिजिशियन का होता है और हर एक कैंसर डॉक्टर करता है. मेरा हक है पेनलेस ट्रांजिशन. सो और मेरा हक है क्योर और मेरा हक है कंट्रोल. सो आई टेल ऑल माय पेशेंट्स विद अ फंडा, डू नॉट डाई बिफोर यू डाई.
thank you.
Control is possible. I may not always cure, but I may always care. मैं हमेशा क्योर नहीं कर पाऊंगा लेकिन मैं हमेशा देखभाल कर पाऊंगा. अगर इन 4-5 पंच लाइन के साथ मैं आगे बढ़ना चाहूं तो अगले दशक के लिए मेरे पास बहुत बोलने को है. थैंक यू सो मच.
Thank you, Dr. Ankur. Dr. Madan
Noticing
Gopal.
only few things. One is raise awareness. That's a key for cancer control. Build capacities because with 250 odd oncologists we have to have a different model. We have to build capacities. Then
Yes.
the common saying that the early detection, putting the person on early treatment, then tracking the patient and managing including palliative care and everything. That's the key. First and foremost is awareness, building capacities, test, treat, track, and manage.
Oh, thank you very much. And this is the time to formally express word of thanks. Now, on behalf of Voice of Healthcare, Giants Healthcare, and UN Global Compact Network India, I would like to express my gratitude and thanks to all the eminent speakers for sparing their precious time with us and sharing wonderful insights and recommendations to strengthen healthcare sector in India. I also express my gratitude to the Voice of Healthcare to conceptualize and design this wonderful panel discussion today and bringing expert at a one platform wherein they made the discussion fruitful and worthwhile with their knowledge and insights. Last but not the least, I would like to thank the valuable audiences for their patient listening and making this event full of participatory and discipline. Thank you very much, all of you. Thank you very
थैंक
much.
यू. शुक्रिया.